Most practitioners encounter a frustratingly common clinical plateau: patients with chronic lower back pain and hamstrings that feel perpetually cramped or tight. The standard response to this presentation is to prescribe a rigorous protocol of repetitive hamstring and lower back stretching in an effort to manually lengthen the tissue. However, clinical data shows that even with strict adherence to these protocols, the tightness inevitably returns. In many cases, the patient actually experiences a measurable increase in lumbar instability. We have to consider the possibility that tight hamstrings and stiff lumbar joints are secondary symptoms. They are the downstream effects of a different mechanical failure. Stretching a symptom without addressing its root mechanical cause traps the patient in a cycle of persistent lumbar pain. We can resolve this paradox through Dr. Nirmali Roy's MSK MPT PhysioPerformax framework. This methodology requires clinicians to shift focus away from overactive secondary muscles and toward activating the inhibited primary mover. Biomechanically, applying a mechanical load cannot correct an inhibited neuromuscular firing pattern. To find where this connection is failing, we must analyze the specific division of labor during hip extension. Restoring the neurological connection to the primary mover provides the only definitive path to permanent lumbar protection. In healthy hip extension, the workload is distributed across 3 muscle groups. The gluteus maximus is the primary engine, designed to handle 70% of the force. This muscle powers our most common movements, including standing, walking, and lifting from a bent position. Modern sedentary habits often lead to gluteal amnesia, where the brain effectively loses its ability to activate the gluteus maximus during these activities. When the glute fails to fire, neighboring muscles absorb the load. The hamstrings jump to 50%, and lumbar extensors triple their contribution to 30%. This load causes significant physical compression of the lumbar facet joints and the L4-L5 discs. The hamstrings shorten to prevent a spine collapse, making manual stretching an exercise in futility. The nervous system is prioritizing spinal safety over muscular length. Prescribing loaded movements like a standard glute bridge at this stage is a clinical error. You cannot move an inhibited muscle into firing. You must establish voluntary motor control before introducing movement. Dr. Roy utilizes tactile biofeedback, where a practitioner applies firm pressure into the lateral sides of the gluteus maximus. The patient must actively push out against those fingers without lifting their hips or arching their back. This is an isolation of the neurological signal, similar to flexing a bicep without moving the elbow. Some patients require several days of practicing this microcontraction to re-establish the neural pathway. Tactile biofeedback ensures the brain is targeting the correct muscle before the lower back is exposed to mechanical load. Even when using the glute bridge, 90% of patients perform the exercise in a way that risks injury. Most patients contract the glute to lift their hips, but they relax the muscle completely during the descent. This relaxation transfers the entire deceleration load directly into the lumbar spine. Dr. Roy's protocol utilizes reverse patterning to eliminate this load transfer. The glute must remain fully contracted throughout the downward eccentric phase until the hips are flat on the floor. Maintaining this tension protects the facet joints and forces the hamstrings to lengthen under control. Eccentric reverse patterning transforms the glute bridge into a protective shield for the lower back. We also use mechanical interventions to prevent overactive hamstrings from hijacking the exercise. First, we keep the thighs strictly parallel. A wide stance inhibits the glute's ability to contract fully. Second, we use foam roller adduction. The patient squeezes a foam roller between their knees while preparing to lift. Squeezing the roller stabilizes the pelvis, creating a solid base for the glutes to fire against. Third, we utilize calcaneal loading. Lifting the toes and driving force exclusively through the heels alters the line of pull. This mechanically disadvantages the hamstrings and forces the glutes to assume the load. Finally, we can use banded abduction. Pushing outward against a resistance and triggers a secondary neural pathway for patients who struggle with adduction. These interventions act as mechanical silencers for compensatory muscles, ensuring the rehabilitative effort reaches the intended target. The ultimate goal of the PhysioPerformax methodology is to reset the body's mechanical math. We return to the ideal distribution, with the gluteus maximus resuming its 70% share of the load. This relieves the hamstrings and lumbar extensors, allowing them to return to their intended minor stabilizing roles. This significant reduction in tension occurs without the use of a single stretch. Flexibility returns as the brain resumes using the glutes to manage the load. Applying loaded movement to an inhibited muscle is a clinical dead end. Success requires a strict order of operations: tactile biofeedback first, eccentric reverse patterning second, and functional load third. Audit your prescribed protocols and discard the stretching fallacy. Clinicians resolve lumbopelvic pain by treating the nervous system before the skeletal system.